Hello and welcome to our new video on ABG introduction. Today my topic is metabolic alkalosis. I am Dr. Vishwat Naik, Assistant Professor, Department of Critical Care Medicine, IMS Syndrome. Coming to first definition, metabolic alkalosis is a primary acid-base disorder due to either loss of hydrogen ion or gain of bicarbonate ion in extracellular fluid. By definition, when the blood pH is more than 7.45 and plasma bicarb is more than 26 mg per liter, then we call it as metabolic alkalosis. This increase in pH induces the hyperventilation, so resulting in secondary increase in pressure of CO2. Thus, metabolic alkalosis is characterized by coexisting elevation of serum bicarbonate, arterial pH, and PaCO2. Coming to incidence and associated mortality, it occurs all about half of the patient in acid-base disease. A direct relationship between the mortality and pH exists when the pH is more than 7.48. It was seen that mortality rate of 45% to up to 80% have been noted when the pH touches 7.55 and 7.65 respectively. Major adverse effects seen when the blood pH is more than 7.6. Now coming to compensation. So when the metabolic alkalosis there is increase in bicarb, so there is compensatory increase in PCO2. So we can predict that PCO2 as 40 plus 0.7 into serum bicarb minus 24. So now coming to causes of alkalosis, there can be divided into two categories like chloride responsive alkalosis when the urine chloride is less than 20 mg per liter, or there is chloride resistant type of alkalosis where the urine chloride is more than 20. And from that chlorine resistant type, there is with hypertension and without hypertension. There are two categories. So coming first to chloride responsive alkalosis. So that includes loss of gastric secretion, which is the major cause of the metabolic alkalosis. That can be caused by vomiting, digestive suction, and loss of colonic secretion. That can be congenital chlorodiarrhea, villous adenoma, and can also be thiazidic and loop diabetes use, or forced hyperkinic state and cystic fibrosis case. Coming to chloride resistant with hypertension, there can be most common is primary hyperaldosteronism, which from that adrenal adenoma is the most common cause. Along with that can be bilateral adrenal hyperplasia, adrenal carcinoma, all that. And second cause is 11 beta hydroxysteroid dehydrogenase enzyme deficiency, or it can be congenital adrenal hyperplasia, current use of diabetes and hypertension, causing syndrome, exogenous mineral corticoid glucocorticoid use, or renovascular hypertension. Coming to chloride resistant without hypertension, it includes Batter Gitelman syndrome, severe potassium depletion, current use of thiazide diuretics, or hypomagnesemia. Coming to other miscellaneous causes, which includes exogenous alkali administration like sodium bicarbonate therapy in renal failure patient, or there can be used metabolism of the lactic acid or keto acids, or milk alkali syndrome, hypercalcemia, intravenous penicillin use, refeeding alkalosis, or massive blood transfusions. That is the flow diagram. Metabolic can be chloride responsive and chloride resistant, and in chloride resistant there can be two types like high blood PP with normal PP. So these are the already we have discussed. So coming to clinical presentation, so how we expect. So symptoms as per se that's not specific. Hyperventilation is mainly due to inhibition of the respiratory center in the medulla. So that can be a major cause presentation of the metabolic alkalosis. Along with mental confusion, obtundation, predisposed to seizure, aggravation of the arrhythmia and hypoxemia in particularly COPD patients can be seen. Symptoms of hypokalemia, associated hypokalemia like cramps, myalgia, muscle weakness are there. Similarly, symptoms associated with hypocalcemia are present like perioral tingling, muscle spasm. How will you approach? First, coming to history, we can ask, is there any vomiting, is there any use of medication like diuretics particularly, or salty sweats like in cystic fibrosis patient, or there is intake of any tablet like soda baker, or any history of massive blood transfusion so that citrate in the blood can convert into the bicarbonate in the liver, or there is use of TPN. So acetate in TPN can be converted into the bicarbonate in the liver, so resulting in the metabolic alkalosis. Or if patient having deafness or recurrent dehydration, then we can suspect Batter syndrome. Or patient having hypertension, so we can look for hypermineralocorticoid states. Now, coming to investigations. So we do urinary chloride. From that we can know the which is urinary chloride sensitive or chloride resistant type of metabolic alkalosis. Then we can do renin and aldosterone. If both are increased, then we can suspect renovascular hypertension or renin secreting tumors. If renin is decreased with high in aldosterone, we can suspect adrenal adenoma or remedial hyperaldosteronism. If both decrease in renin and aldosterone level, then we suspect Cushing-Liddle syndrome or adrenal enzyme deficiency disorders. And if we suspect in Cushing syndrome, then urinary cortisol has to be raised. Then coming to management. So first category is chloride responsive metabolic alkalosis, where we should mainly re-expand the volume by normal saline. That's the main treatment. Along with, if there is potassium depletion, then we can supplement with potassium. So alkalosis is associated with severe hypokalemia, will be resistant to volume restriction, so that we first supplement with potassium. And we use PPI if there is vomiting or nasogastric aspiration, so to prevent further loss of the hydrogen ion. And when stop diuretics, so our volume will be not reduced. And hydrochloric acid and ammonium chloride only in case of emergency. And hemodialysis in patient with mild renal failure. Then coming to chloride resistant type of, there we can mainly surgical removal of the mineralocorticoid producing tumor to be done, or we can use aldosterone inhibitors or AC inhibitors, or should stop the steroid, or we use potassium depletion in case of potassium depleted state. So coming now to medication in as a summary. So what are the medications we used in this type of acid-base disorder? So first, coming to acetazolamide, which is a carbonic anhydrase inhibitor, that enzyme which catalyzes the hydration of CO2 to and dehydration of the carbonic acid. So inhibition reduces the reabsorption of sodium bicarbonate in the proximal table, leading to natriuresis, bicarbonate diuresis, and a decreased serum bicarbonate level. Second is hydrochloric acid. The IV hydrochloric acid may be indicated in severe type of metabolic alkalosis when the pH is more than 7.55, or when the sodium chloride or potassium chloride cannot be administered because of the volume overload or advanced renal failure. In that case also we use the IV hydrochloric acid. Or it is indicated if there is rapid correction of severe metabolic alkalosis is warranted, like in case of cardiac arrhythmia or hepatic encephalopathy or digoxin toxicity. Third one is ammonium chloride. It's indicated in severe type of metabolic alkalosis related to chloride deficiency. So it converted to ammonia and hydrochloric acid by the liver and decrease the blood pH. Next is potassium sparing diuretics. From that, triamterene that interferes with potassium sodium exchange active transporter in the distal tubule collecting duct and cortical collecting tables. And second is amiloride, is potassium conserving anti-caloritic or diuretic agents It is an anti-cholinergic drug compared to the thiazides. Then is corticosteroid used in glucocorticoid remediable hyperaldosteronism. So here dexamethasone is used. We suppress the cortisol production by inhibiting the ACTs, mainly in the Cushing syndrome. Then is NSAID. It is partially correct metabolic alkalosis in Bartter syndrome and Dietland syndrome only, like ibuprofen or indomethacin.